Good afternoon. I am Professor Anne-Geneviève Marcelin. I'm virologist in Pitié-Salpêtrière Hospital and Professor of Virology at Sorbonne University in Paris. It's a great pleasure to open this 2020 European meeting on HIV and hepatitis, treatment strategies and antiviral drug resistance on behalf of my colleagues from the organizing and scientific committees. We had to organize this meeting as virtual given the COVID-19 pandemic, and I am very disappointed that I cannot welcome you in person in Paris. Anyway, we have a wonderful program with excellent speakers from Europe and North America. And we will have time for roundtables, questions and answer sessions with the speakers. Thank you to our corporate support, Viv Healthcare and Jade that give support for this meeting. This meeting is CME accredited, so you can ask for European CME credits. Please complete a short survey after each session, and this survey will be sent to you by email after the meeting, and the certificate of attendance will be sent to you after completion of the survey. We have two special moments in the program. The Andrea De Luca Lecture and the Ricardo Camacho Awards to commemorate two prominent members of our organizing and scientific committees who passed away too early. The Ricardo Camacho Awards will award the best abstract presentation and will be given Friday at 16. So today's program, we will start with the session 1 on challenges in Central and Eastern Europe, then a special session on first day treatment with a European perspective, and then a session on clinical management of HIV, and then we'll finish by the poster viewing session. So this is very important. Do not hesitate to ask a question. We have a live question and answer field, and you can type your question. Do not hesitate. It's very important that we can have some interactions. And so we will start the first session, the opening session, with the Andrea De Luca lecture on the top 10 papers published in HIV in 2019 and 2020. This talk will be given by Dr. Jade Ghosn. Dr. Jade Ghosn holds the position of Associate Professor in the Department of Infectious Disease at Bichat University Hospital in Paris, and is teaching in Bichat School of Medicine, Université de Paris. Jade has an MD in internal medicine and infectious disease and a PhD in virology, and is deeply involved in the ANRS therapeutic strategies group for the treatment of HIV infection. I know this was a very hard work to prepare this lecture, so thank you so much, Jade. Thank you very much. So let's start with this opening session.
Good afternoon, everyone. I'm very happy today to open this virtual conference. I'm more than happy about the organizers to have committed to maintaining this conference regardless of what's happening in our world currently. I think we all need to connect with each other and to talk about something else than COVID-19 for a couple of days. And it's really very, very good to have this exciting program and to be the one to open this conference. So I'm gonna give you an overview about the top 10 papers of the year. And of course, this talk is dedicated to our friend and colleague, Andrea De Luca. And I also like to take this opportunity to thank Charlotte Charpentier, who really helped me in selecting the articles and interpreting some of them. So this is what we're going to go through. Of course, given the current epidemic, I could not but talk about COVID-19 and HIV. Then we'll go through antiretroviral therapy with the NAMSAL trial and the cabotegravir and rilpivirine long-acting latest data. We'll move on to PrEP with HPTN 083. And I know it's not published yet, but I think it's really important to talk about this study with these amazing results. We'll also talk about islatravir, and then we'll finish with HIV reservoir. So let us first start with COVID-19 and HIV. And with the first question, are people living with HIV overrepresented among COVID-19 patients? So I chose to present you the ISARIC prospective cohort with a focus on the UK data gathered between February 6th and April 18th, 2020. More than 1,600 patients with COVID-19 were enrolled in this cohort with a median age of 72 years, a median time between symptoms onset and admission of 4 days, and a median time between admission and discharge of 7 days. 49% of them were discharged alive, 33% died, 17% required ICU, and of whom 45% died, and 17 were still hospitalized at the time of the analysis. So when we look at comorbidities that these patients had, you see that here, the most common comorbidities were those who are already described within other studies. But as regards to HIV and AIDS, less than 1% of the participants had HIV or AIDS. So clearly, HIV is not overrepresented in COVID-19 disease. So if it's not, is it associated with COVID-19 mortality in those who develop COVID-19? So the first paper I wanted to discuss is the cohort study in public hospital in Cape Town, South Africa. The aim of the authors were to assess the association between HIV infection and COVID-19 mortality between March 1st and June 9th, 2020. And they used Cox proportional models adjusted on age, gender, home location, and comorbidities. Among more than 3 million participants, 22,000 had COVID-19 and 625 died. Among the comorbidities associated with COVID-19 mortality, we could find male, gender, age, diabetes, hypertension, chronic kidney disease, and HIV. As you see here on both graphs, HIV was independently associated with an increased risk of mortality among patients hospitalized for COVID-19 and among all of those who had a confirmed COVID-19 disease, with an adjusted hazard ratio at 2.14. On the other hand, another study, the TreeNet network performed in the USA, collected data on more than 15,000 individuals COVID-19. 49,763 were HIV negative and 404 were HIV positive. And they were matched one by one for BMI, diabetes, hypertension, chronic lung disease, chronic kidney disease, race, smoking, and gender. And the authors used propensity scores. while crude mortality was higher in HIV-positive individuals, after propensity score matching, there was no difference in COVID-19 mortality between HIV-negative and HIV-positive patients, which means that mortality is rather driven by the high burden of comorbidities in HIV-infected patients rather than HIV by itself. And finally, to conclude with the COVID-19 chapter, what about the severity of the disease in people living with HIV according to the antiretroviral regimen? So this is the study of the Spanish hospitals, 60 hospitals in Spain with more than 77,000 individuals followed for HIV. This was a prospective cohort between February 1st and April 15th, 2020. And the objective was to describe the incidence and the severity of COVID-19 in people living with HIV according to the NATI backbone use. They measured cumulative incidence of confirmed COVID-19, hospitalization for COVID-19, admission to ICU, and death. And all this according to an NATI backbone with a Poisson regression. And here is the flow chart of the study. 77,000 patients, of whom 236 had a confirmed diagnosis of COVID-19. 151 were hospitalized, 85 were outpatients. And you can see on the diagram, those who were admitted to ICU and those who were admitted in medical wards. And among those admitted to ICU, five died and 10 recovered. Among those admitted to medical wards, 12 died and 124 recovered. And you have in the box down of the graph, the backbone of NATI that they were receiving: abacavir-3-TC, TAF-FTC, TDF-FTC. And you can see in all the boxes that the patients receiving TDF-FTC were more likely to be represented among those who recovered rather than those who were receiving abacavir-3-TC or TAF-FTC. So these are the final results. As regards the risk of confirmed COVID-19 diagnosis, regardless of hospitalization, of being an outpatient, just the fact of having contracted COVID-19 disease. The risk was the highest for those receiving TAF-FTC and the lowest for those receiving TDF-FTC. This was the same among those who were hospitalized for COVID-19 with regards to the lowest risk with TDF-FTC. However, the highest risk here was for those receiving abacavir-3-TC. So the conclusion was for the study that the lowest risk of COVID-19 diagnosis and hospitalization could be associated with the fact that TDF-FTC had a protective effect on COVID-19. So this remains to be confirmed by larger studies, and this could be interesting to perform such studies in people receiving PrEP who don't have any other comorbidities. So let us move now to antiretroviral treatment with the NAMSAL study assessing the efficacy of dolutegravir versus low-dose efavirenz in first-line CART. This was an open-label non-inferiority trial performed in Cameroon. This trial enrolled antiretroviral naive participants with an HIV RNA above 1,000 copies per ml, and participants were randomized to receive either TDF-3-TC plus low-dose efavirenz 400 milligrams versus TDF plus 3-TC plus dolutegravir 50 milligrams once a day. The primary endpoint was to achieve an HIV RNA below 50 copies at week 48 by snapshot analysis, and non-inferiority margin was 10%. Here are baseline characteristics of the participants. I won't go through all the details of the table, but I just wanted to point out that a third of the participants had a pre-therapeutic HIV RNA viral load above 500,000 copies, and also a third of the participants had a CD4 cell count below 200 per cubic millimeters at baseline. So these are the patients that are the most hard to treat. So these are the results of the primary endpoint, which was virological suppression at week 48, which was achieved in 75% of participants in the dolutegravir arm and 61% of participants in efavirenz low-dose arm. So these results are a little bit lower than those expected with regards to what has been already published in the literature. I wanted to remind you that DTG efficacy in single was 88%, DTG efficacy in Flamingo was 90%, and efavirenz 400 efficacy in Anchor 1 was 82% at week 48. So clearly here we have lower percentage of patients achieving virological suppression at week 48 than those we saw in other trials. This might be due to the high proportion of patients with high viral load and low CD4 at baseline. Let us check for non-inferiority now, and you can see here that in the intent to treat population, the per protocol population, in the subgroups of baseline viral load below 100,000 copies or above 100,000 copies, non-inferiority was demonstrated, but there were no superiority of DTG versus efavirenz. So again, DTG is non-inferior to efavirenz 400 milligram for first-line treatment, but is not superior in this study. What about resistance? So HIV drug resistance was performed retrospectively on baseline samples. There was a predominance of CRF02, 57% in the DTG arm, 63% in the efavirenz arm. Primary resistance to NATI was low, 1.3%. However, primary resistance to NNATI was 6.1%, and this accounted for 37 participants, including 35 of them with efavirenz resistance-associated mutations present at baseline. And of note, there was a high level of integrated genetic polymorphism, with 51 participants harboring the E157Q mutation in the integras genes, which represents 8.4% of participants. Multivariate analysis did not show any association between the presence of primary resistance, including efavirenz resistance-associated mutations at baselines, and the absence of virological suppression at week 48. So there was no impact of this primary resistance to NNATI or to integrase inhibitor at baseline on the outcome at week 48. There were 3 failures in the DTG arm, no DTG resistance at baseline, and no resistance emergence at the time of failure. There were 16 virological failures in the efavirenz arm. 5 of them had efavirenz resistance mutation present at baseline. 1 had efavirenz N3TC and TDF resistance at baseline. 2 acquired efavirenz resistance at failure. 3 acquired efavirenz N3TC resistance at failure. 3 acquired resistance to the 3 drug at failures, and 2 had no resistance detectable at the time of failure. So this is something very that we should look into, the fact that pre-existing resistance mutation, primary resistance, did not affect the outcome. However, the efavirenz arm seems really less forgiving than the DTG arm. There was more virological failure in the efavirenz arm, and in the event of virological failure, the emergence of resistance mutations was more common in the efavirenz arm than in the DTG arm. What we should also look out is that the mutation 157Q in the integras genes, it is part of the French algorithm for possible resistance to DTG QD, and as you can see here, it didn't seem to affect the results. Let us move now to dual therapy with cabotegravir rilpivirine long-acting and the FLAIR trial, which was recently published in the New England Journal. In this trial, naive patients went through an induction phase of 20 weeks of oral DTG plus abacavir plus 3TC, and then after 20 weeks of oral triple drug induction, they were randomized to continuing this triple oral drug combination or to switch to a first daily oral dual therapy with cabotegravir rilpivirine and then monthly injection of CAB plus rilpivirine long-acting until week 96. These are the results. As you can see here, more than 93% of the participants were able to maintain virological suppression in the dual therapy long-acting arm and in the oral therapy maintenance arm. And 4 of them discontinued treatment for lack of efficacy. 1 out of the 4 was the woman who had a false positive pregnancy test, and treatment was discontinued when the false positive test was performed. And by the time the confirmation showed that she was not pregnant, she resumed treatment and she had reached the protocol-defined virological failure, and then she was switched on another treatment. Regarding the 3 other participants who experienced protocol-defined virological failure in the long-acting group, all 3 had a BMI above 30, plasma drug levels in the lowest quartile, HIV subtype A with the L74I integrase polymorphism, and all 3 had emergence of NNATI and INSTI resistance associated mutations at the time of failure. So let us look into those participants who were harboring an HIV subtype A and those who were harboring the polymorphism L74I in the integrase genes. As regard HIV subtype A, 8 participants in the long-acting group were harboring this subtype. 5 maintained virological suppression and 3 experienced virological failure. When we look at those who were harboring the L74I polymorphism, 54 participants had this polymorphism at baseline, and 51 out of 54 were able to maintain virological suppression on cabotegravir plus rilpivirine long-acting maintenance therapy. What about PrEP and the scoop with the cabotegravir long-acting efficacy within the HPTN 083 study that was presented this summer in the AIDS conference? So this is the study design. Cabotegravir injection performed every 2 months were compared with TDF-FTC taken orally and on a daily basis. First, all participants took cabotegravir orally or cabotegravir placebo for 5 weeks, and then, if they did tolerate it, they were switched to the step 2 phase of the study with cabotegravir injection every 2 months with TDF-FTC placebo orally, or placebo of cabotegravir injection every 2 months with active TDF-FTC taken orally on a daily basis. And this was planned to last for approximately 3 years, and then step 3 was a daily intake of TDF-FTC orally to cover the tail of cabotegravir. So these are the results. There were 52 HIV infections in more than 6,000 patient year of follow-up. And as you can see here, 13 infection in the cabotegravir long-acting arm and 39 infection in the TDF-FTC arm. So as you can see on the right-hand side of the figure, cabotegravir was not only non-inferior to TDF-FTC, but it was also superior to TDF-FTC. Let us look into these 13 incident HIV infection in the cabotegravir long-acting arm. The first 2, A1 and A2, had an HIV infection that was documented at baseline. So it means that they got infected between screening and baseline. So it's not a treatment failure. They got infected before starting the therapy. B1, B2, B3, B4, B5, in these patients, they got infected on the long-acting step 2 phase, but all of them had more than 2 weeks overdue delay between 2 injections. And they probably got infected between this overdue delay between 2 infections. So we can assume that they had non-protective levels of drug in the plasma, but we don't have drug concentration available yet for these ones. C1, C2, C3 were infected during the oral phase of cabotegravir. So we may assume that they had some adherence issues in this short oral phase, which might explain the fact that they got infected. And what is really challenging are participants D1, D2, D3, D4, D5. They got infected during the cabotegravir long-acting injection phase, and they did fully respect the interval time between two injections. So there is no obvious reason for them to get infected. And we really need to have pharmacological measurements for these patients and to check whether they had sufficient drug concentration in plasma at the time they got infected. Another long-acting drug is islatravir, which seems very interesting because it's given orally. And this is the study that was performed in male macaques. And they tested several doses of islatravir. This is the first study. Macaques were challenged with low-dose intrarectal sheave every week, and they received weekly oral gavage with MK8591, which is islatravir, 3.9 milligram per kilo per week for 14 weeks. You can see on the graph here at the bottom of the page that all macaques who were receiving islatravir at the dose of 3.9 milligram per kilo per week were protected, while all the controls got infected after a maximum of 4 challenges. Here you have HIV RNA that was measured in all the controls. In all of those who got infected had an HIV RNA detectable. And on the graph here, you can see the concentration of islatravir intracellular concentration of islatravir in PBMC, which were really as expected. So the next step was to lower the dose. So they performed the same study with islatravir 1.3 milligram per kilo or islatravir 0.43 milligram kilo per week. And you can see here that with both doses, 100% of the animals were protected, while all the control animals got infected. And here is the concentration of the islatravir at the dosage of 1.3 milligram per kilos at the end of the study, the washout period, and then the concentration when the 0.43 milligram per kilo study was started in the same macaques. And finally, the lowest dose of 0.1 and 0.025 milligram per kilos per week. And with these two low doses, 6 out of 8 animals were protected with the dose of 0.1 milligram per kilo, and only 2 animals were protected with the dose of 0.025 milligram per kilo. So this means that islatravir shows promising results at dose higher than 0.1 milligram per kilo per week in a macaque model, and this support future studies in humans with a monthly administration of islatravir taken orally once a month, and the studies are about to begin shortly. So let us move now to the reservoir section with 2 papers that were recently published with very interesting results. The first one assessed the reservoir in elite controllers versus patients who achieved HIV RNA below 50 copies on combined antiretroviral therapy. The first results that they were able to produce was that the proportion of intact provirus was higher in elite controllers, as you can see here depicted in pink, rather than in those who achieved an HIV RNA below 50 copies on combined antiretroviral therapy. And this was regardless of the integration sites. So the proportion of intact provirus is higher in elite controllers than in those who achieved control on antiretroviral therapy. The second interesting result is, where is this intact provirus located and what is the integration site? And you can see here on this picture that intact proviruses were more likely located in centromeric satellite DNA or in zinc finger genes of chromosome 9. Both locations are associated with heterochromatin feature, and this was significantly more common in elite controllers than in those who achieved virological control on CAR. So in elite controllers, intact proviruses are located in centromeric satellite DNA or in zinc finger genes on chromosome 9. And finally, they were also able to show that integration sites of intact proviral sequences from elite control were distant from transcriptional start sites and accessible chromatin of the host genome. This means that in these elite controllers, intact sequences of proviral viral DNA are far from transcriptional start sites and accessible chromatin. Moreover, they also showed that integration sites of intact proviral sequences from elite controller were enriched in repressive chromatin marks. So all this contributes to the absence or the very low replication in these individuals in comparison to what happens in chronically infected patients. And finally, the last paper I wanted to talk to you about is the one who assessed the potential effect of compartmentalization and cellular residency on integration sites. For this study, authors gathered PBMC and lymph nodes mononuclear cells from cervical and inguinal lymph nodes from acutely infected individuals and from chronically infected individuals. They also gathered tonsils from CAR-treated individuals. And they did compare integration sites between the subsets of CD4, central memory, effector memory, and between CD4 and lymph node mononuclear cells. And this is what they saw. As you can see here, in acute, chronic, or CAR-treated individuals, there was little overlap between or within CD4 cell subsets or tissue compartments. There were only 8 shared integration sites over more than 3,000 integration sites that were studied. So this means that there is not that much of exchanges or traffic between compartmentalized CD4 in peripheral blood and in lymph nodes. So with that, I'd like to thank you. I wish you a very exciting conference and hope to see you soon on another occasion. Thank you.
Go. Thank you very much, Jade, for this excellent overview. Jade won't be there for the question and answer session, so I think we can directly move on to the next session that will be chaired by my colleague Anne-Mieke Vandamme. Please, Anne-Mieke.
Thank you, Anne-Geneviève. Thank you very much. I'm really miss not being in Paris right now, as probably all of you. So I'm chairing this first session, and the first session is about challenges in Central and Eastern Europe. We will have 2 invited speakers. I will announce each of them, and then we have 3 abstract-driven presentations, which I will announce as a block. So the first invited speaker is Dr. Teymur Moori, a psychologist at ECDC, and he is responsible for monitoring HIV response in Europe and Central Asia, and also involved in monitoring hepatitis B and C response. And he's also working on migrant health and infectious diseases. So Teymur Moori, please, We are eager to hear from you about the epidemiology of HIV and hepatitis in Central and Eastern Europe.
Thank you for that kind introduction. So I'll be giving a few slides here on the epidemiology of HIV and hepatitis in Europe and Central Asia. So I am employed at ECDC and I have no conflicts of interest to declare. So this is going to be the outline of my presentation. I'll try and provide some background to hepatitis and HIV in the context of the Sustainable Development Goals. Then I'll move on to show you how countries in Europe and Central Asia are progressing towards achieving targets when it comes to hepatitis B and C, as well as HIV, and I'll make some final conclusions. So the Sustainable Development Goals, you're all very familiar with these goals. Goal 3 is related to health, and Goal 3.3 is where we have specific targets and goals related to HIV as well as to hepatitis. So let's start with hepatitis B and C. So WHO has been the leading force behind developing a global health sector strategy on viral hepatitis, which goes up until 2021. And WHO European office in Copenhagen developed a specific action plan for the health sector response for viral hepatitis. And both of these strategies have specific goals for the European region. So there are 2 impact targets that would need to be achieved by 2030, and those are related to incidence and mortality. And according to WHO modeling, we need to see a 90% reduction in new infections by 2030 in order to be eliminating hepatitis by 2030. And when it comes to death, we need to see a 65% reduction by 2030. And as you see, we have interim targets of 30% reduction in incidence and 10% reduction in deaths by 2020. In addition to these impact targets, they developed so-called service coverage targets that would need to be eliminated by 2030. And these are some of the targets that have been developed by WHO. You see the best baseline here on the first column, 2015. You see the targets for 2020, and on the far right-hand side, the targets for 2030. When this global health sector strategy was developed, it was estimated that the European region is doing relatively well when it comes to hepatitis B vaccination for infants, as well as prevention of mother-to-child transmission and blood safety. These are the percentages in green circles. But we're pretty far away when it comes to injecting safety, harm reduction, testing, and treatment for both hepatitis B and C. And these are the percentages in the red circles, where we're pretty far away from achieving these targets. So ECDC does not have very good, strong data and modeling estimates around viral hepatitis, and we have several big projects ongoing. In the meantime, we have to rely on published literature, and this shows you here that the estimated number of people living with hepatitis B virus in the EU EEA is 4.7 million, and for hepatitis C, that number is 3.9 million. The estimated percentage undiagnosed for hepatitis B virus is anywhere between 40 and 85% in EU countries. And for hepatitis C, that number is between 20 and 91%. So there's a huge range here of uncertainty. But what's definitely clear is that a significant proportion of people are living with undiagnosed virus. So testing is a key priority in our region. So I'm going to zoom in on the continuum of care for hepatitis C. We have this for hepatitis B as well, but I'm going to focus now on hepatitis C. Here you see one of the key issues in our region is the availability of data. So this shows you the number of countries reporting data for each stage of the continuum of care for hep C. So only 21 countries have estimated numbers of infected, 16 countries have numbers on the diagnosed, and 12 respectively for people on treatment and those who are sustaining viral suppression. So the availability of data is not very good for hepatitis C. So how are we doing? So this slide shows you the proportion of people living with hep C who have been diagnosed in the EU in 2017. So 16 countries have data available for this area. 7 countries, as you see here, have reached the target of 50%, which is the target for our region. And the remaining countries with data are quite far away from this 50% target. But again, as I said before, approximately half the countries in our region have no data whatsoever on the number of people diagnosed. Moving on to the second target, so the portion of those who have been diagnosed with hep C should be on treatment and here we have 12 countries with available data. Only one country, Iceland, has reached the target of 75%. The remaining 11 countries are very far away from this 75% target. And as you see here, approximately 18 countries have no data whatsoever in this area. And on the last target, you see here the proportion of patients on treatment for hepatitis C who should have been cured. Again, only 12 countries have data for 2017, but the positive thing here is that out of those 12 countries, all of them have reached the 90% target. So this is not surprising. We know treatment for hep C is very effective. So once you are put on treatment, you are going to be cured. But again, you see the number of countries, 18 countries without any data available, which is of huge concern. So that's all on the hepatitis B and C. I'm going to move on now to HIV. And here, UNAIDS is the body that have developed the definition for what it means to end AIDS by 2030. They've developed these targets showing here. So we need to see 0 new infections, 0 deaths, and 0 discrimination by 2030. And to achieve this, they've developed so-called fast-track targets, where they want to see a reduction in new HIV infections to fewer than 500,000 by 2020, reduce deaths to fewer than 500,000 by 2020, and eliminate stigma and discrimination by 2020. So what does this mean in terms of specific targets for Europe and Central Asia? So we have an incidence reduction target of 75%, which is quite clear. We have PrEP targets globally, but we don't really know what that means for Europe. There's no specific target for Europe. We have the so-called 90-90-90 treatment target, which I'll speak about shortly. Those are crystal clear. But then when it comes to mortality and stigma, the targets for our region are quite unclear, as well as the measurements. So we don't have very poor data around these issues. So we do joint HIV surveillance together with WHO Europe, and this is the latest data we have from 2018, showing you that approximately 142,000 people were diagnosed with HIV in our region. 16% of these cases were diagnosed in the western parts of the region, 5% in the center, and a full 79% in the eastern parts of the region. You see the rates per 100,000 population at the bottom of these bubbles, and you see the huge difference in Eastern Europe, where the huge burden of HIV is in terms of burden in our country, in our region. In terms of HIV modes of transmission, those differ quite substantially within our region. They're quite similar when it comes to the West and Center, where you see that approximately 50% of diagnosed cases occur among men who have sex with men, followed by heterosexual contacts, and only 4% among injecting drug users. In the eastern parts of the region, the majority of transmission occurs among heterosexual contact, both men and women, followed by injecting drug use, and only 5% among men who have sex with men. Another big difference in our region is this issue of migration, whereas in the western parts of the region, migrants account to almost 50% of all diagnosed cases in 2018. That falls to 10% in the center and only 1% in the eastern parts of the region. So moving on to the 90-90-90 treatment targets. So these targets are based on UNAIDS modeling, where it suggested that 90% of all people living with HIV should be diagnosed by 2020. Out of those, 90% should be on treatment, and out of those on treatment, 90% should be reaching viral suppression. If we reach these 3 targets, at least 73% of all people living with HIV should be virally suppressed. And according to UNAIDS modeling, that would put us on track to reach 0 infections by 2030. So let's see how we're doing in this region, and starting with the first 90. So here you see that we have 43 countries that are able to have estimates on this. And if you remember what I said on hepatitis C, very few countries had that for hepatitis C, but many more countries have this estimates for HIV. So 43 countries have data. The overall percentage in our region is 80% who know their status. The target is 90%. You see the countries on the left-hand side in green bars. Those are the countries that have reached the targets. The countries in blue here are the ones above the regional average and which we think are on track to reach these targets. And on the right-hand side in orange, you see the countries that are below the average, and especially those to the far right are going to have huge problems achieving these targets. Okay, let's now go on to the second target. So once you are diagnosed, you need to be put on treatment. Here we have even more countries, 45 countries with estimates. You see that the overall percentage is much lower here, 80 for the first target. Here we're at 65% of people that are diagnosed who are put on treatment. More countries have reached this target in green here, but as you see in the far right-hand side, Russia is below 40% of people that have been diagnosed on treatment, and that pulls down the whole regional average. So countries in orange are very far away from reaching this target. So once you are on treatment, are you reaching viral suppression? So here we have 38 countries with estimates. The overall percentage here is 86%, so pretty much on track to reach this target as a whole, our region. That's not surprising. We know that treatment is very effective. So once you are on treatment, you will be reaching viral suppression in a certain amount of time. So let's see then how many countries are on track to reach this 73% overall target. So 36 countries have data across the continuum. See, these are the 36 countries we're able to do these estimates on. And as you see here, the overall percentage is currently at 44%. So we're quite far away from reaching these targets in our region. Approximately half the countries on this list, up until I would say Croatia, are pretty much on track, but from Slovakia onwards are not going to be reaching these targets by 2020. So to conclude, are we on track to end AIDS by 2030? So looking at the incidence target that I talked about before, this shows you, in the red line shows you all WHO European regional estimates of new infections, and the green lines I've singled out the EU countries because they differ quite dramatically. So the fast track target suggests that we should see a 75% reduction in new infections by 2020 using 2010 as the baseline. So looking at 2010, the red line, we have 119,000 cases and we need to see a 75% reduction. The latest estimates we have show actually an increase of 28% in the wider WHO European region. And if we're looking at the EU countries only, we're seeing a slight decline, but we're far away from the 75% target. And this is where we need to be this year, 2020. So you see, it's going to be virtually impossible for us to be reaching these targets, not only in the region as well, but even in the EU, it'll be very difficult or virtually impossible to reach these targets. In terms of the 90-90-90 targets, as I showed you, 80% of all people in our region have been diagnosed. 50% of all people living with HIV are on treatment, and 43% of all people living with HIV have reached viral suppression. And you see the targets in the red lines above. But there are big sub-regional differences in our region. In the western parts of the region, I would say that we are on track. We've already met the 73% viral suppression target in our region, in the western parts of the region. But when we look at the center and east, this is where the big problems occur, and especially when it comes to treatment. So we're doing okay on the diagnosis and the testing. I would say we're still far away in the eastern parts of the region, but we're doing relatively okay. Where the big drop-off happens is putting people on treatment once they are diagnosed. That's the biggest problem we have in our region currently. So to conclude, for hepatitis B and C, I think it's fair to say that we have a lack of solid epidemiological and modeling estimates to guide effective responses and to measure progress towards these targets. The estimates that we do have show progress when it comes to hepatitis B vaccination and blood safety, but major challenges in terms of prevention, testing, and treatment. ECDC has launched its first ever monitoring system for hepatitis B in 2019, and we're just about to launch the next one, 2021, where we're trying to support countries develop estimates across all these targets and goals. When it comes to HIV, I think it's fair to say that we have solid epidemiological and modeling estimates to guide and effective responses and to measure progress towards key targets. Overall, our region is not on track to meet the target of a 75% reduction in new infections by 2020. And when it comes to the treatment target, in the western parts of the region, we're doing relatively okay with these targets. But when it comes to the central and eastern parts of the region, we're lagging far behind. And in terms of priorities for the full region, we need to scale up testing. We need to link people to treatment once they have been diagnosed. And we have gaps still when it comes to opioid substitution therapy and needle exchange programs, especially in the eastern parts of the region. And PrEP for the full region is still a gap area. So I would like to thank colleagues at ECDC, WHO, UNAIDS, and our consultant team who have helped with this analysis. Thank you very much.
Good afternoon, everybody. It's really a pleasure to be here and to talk about one key issue that is really important for me, So we'll be talking about some challenges in Central and Eastern Europe, and we'll be focusing on transmission and acquired resistance, and we'll be focusing on a special population. So regarding this presentation, I have no conflict of interest, and we will be talking about an overview of HIV resistance data. What are the available data for 2020? Then we will be focusing on special population, as the title of the presentation was already emphasizing. As I am a Romanian physician, of course, my special population will be the Romanian experience of long-term survivors. And we'll be looking at some data. And again, we will finish by getting back to resistance, transmitted or acquired. So what do we mean by resistance to antiretrovirals? And what is the idea of the resistance and especially the clinical outcomes of it? We know that we want to have a successful treatment for our patients. And when we talk about heart, we need to have it as robust as we can in order to do not jeopardize our drug resistance. So we can either have a resistance that is present at the time of transmission, so-called transmitted resistance, or we will have a resistance that evolved during treatment with multiple antiretrovirals. And that is due to the fact that we will not achieve complete suppression with the HIV replication. So the successful of the treatment will depend on the sensitivity of the HIV to the drug in the treatment regimen, and we can do that by doing the baseline resistance that will underline any transmitted resistance, and that baseline resistance can have an worsen of the outcome, but that resistance testing will really help improve the outcome. So I made a few cartoons downstairs where you can see the resistance over here, which can be either transmitted or acquired. And we will be focusing on this nice special population because the impact of resistance is really important on special ones. So what will be the evolution of the HIV drug resistant mutation during the treatment? It may be driven by several causes, like suboptimal adherence that we already talked about, drug-drug interactions that we know that can affect the level of the antiretrovirals, the high baseline HIV viral load and the low CD4 count, which we know that are two parameters that are really important to measure and keep an eye on it, and the use of antiretroviral regimens that do not exhibit adequate activity against our HIV strain. So we do need to choose the right treatment at the beginning and think about all of that in order to rule out resistance. Resistance can happen. And we have the recommendations. This is really an old slide, so to say, from the beginning of the EX recommendation that we will say that when we want to overcome the resistance, we really need to use at least 2 or 3 active drugs in a new regimen when we change the regimen. Because we talk about resistance, we cannot talk about resistance from the point of view of the treatment. So we need to keep an eye on that or whenever we will do the switching for this kind of patients. This is a slide from an article that was published a few years ago in 2012, but it's a nice gathering of the authors from the Balkan area, from our area, virologists, top virologists that look about the HIV molecular epidemiology in the Balkans. And they call it a melting pot of high genetic diversity. Us as human beings are diverse and also the virus. So you can see over here the strains of the virus that are really a little bit special in the area. And as I told you that I am a Romanian physician, you can see that Romania is special from the point of view of the strains. So we have subtype F that we may have an impact on resistance and also on our long-term survivors, the population that we'll be focusing. So we do know that we have the resistance that is common against antiretroviral treatment experienced patients. There are some recent studies that will say that around 78% of the antiretroviral treatment treated individuals will have a phenotypic resistance to antiretrovirals. 51 of them will have resistance to 2 or more antiretroviral classes, and 40% will have a triple class resistance, which is quite a high number. So what we can gain from this study is that we will have a pool of patients hard to treat in the near future with resistance to even 3 classes of antiretrovirals. So there are some other studies done a few years ago that underline that we have a resistance in newly diagnosed untreated patients, so that transmitted resistance that we talked about, around 40.5%. So we do have guidelines, European guidelines, EACS, the US guidelines, DHHS and EAS guidelines that will say that we do recommend testing for resistance prior to selecting the antiretrovirals for acute infections, chronic infections, and treatment failure. So nowadays, we do have the recommendation to test for resistance. This is another article that was published last year and will underline what will be the prevalence of resistance in the area where I am from. So the European area, the central southeast part of Europe. Otherwise called. So over here you can see that it was identified a resistance of 10.7 for Hungary, Serbia around 9%. When we talk about Croatia, less than 22%. When we talk about Greece, 19.6%, and the resistance that was identified for Romania of less than 10%, for Bulgaria around 5%. So we do have identified resistance in patients that are under our care. And these are really recent data published last year. There are a few areas for which we do not know the exact prevalence of resistance. This is another nice study that these are unpublished data nowadays. It was given to me by my colleagues in the lab. So we talk about transmission of HIV drug resistance and the predicted effect on current first-line regimen in Europe. How will this change our way of thinking when we look at our patients? And these are a few data that are extracted from their for that unpublished data that I want to focus around. So transmitted drug resistance in Europe is around 8.2%. And if we will focus for Romania, it's around 4.7%. And mainly the transmitted resistance is responsible for NRTIs. And you can see over here the graphs comparing different years of transmissions. So they were gathered by groups of years. The last years, we seem to have a drop in the overall resistance, but the trends are similar for all 3 categories, NRTIs, NNRTIs, and PIs. On the other hand, when we looked at the last year data regarding transmission and what will be the main mutation that we'll have to think about it and identify for the NNRTIs, for example, you can see over here that we talk about the more frequent mutations, the ones that we are expected to see in a population that was treated and that will come into contact. So last year, we haven't identified any transmitted drug resistance for integrase inhibitor in the newly diagnosed patients that were tested. On the other hand, when we looked at the pool of data in our lab, and we looked at newly diagnosed and also biological failure, a few more with biological failure, we identified 1 or more mutations, major mutation in 70 patients, 2 or more mutation in 26, and again 3 or more mutation in only 11 patients. I didn't do the percentage because they are not relevant, but if we think that each of these numbers are really patients for which we have to identify and clarify a way to treat them, it will get more important. So looking at the Stanford resistance database for which we'll pull the data, and looking at what will be the most frequent mutation identified for integrase inhibitors, you can see that N155H was the most frequent identified, that we know that is a non-polymorphic mutation that is selected in patients that will receive integrase inhibitors like tegravir, elvitegravir, and rarely for dolutegravir patients, and it's associated with high level reductions as a susceptibility for altegravir or elvitegravir, and it caused a low level reductions in dolutegravir susceptibility. So it's one important mutation. Looking at other mutations, here I only want to emphasize that this mutation that will go in combination, the 140 will go with the 148, and the effect that will have on integrase inhibitors, you can see underlined in the slides, but we need to look at this mutation in combination, and we really need to see their impact on the so-called second-class integrase inhibitors like dolutegravir and tegravir. If we want to say something about E138K, which again is a non-polymorphic mutation that is selected in patients receiving raltegravir, elvitegravir, and even dolutegravir, we know that this really occurs in combination with Q148 mutation, and alone they do not reduce the susceptibility of integrase inhibitors. However, they occur in combination with Q148 mutation. They are associated with a high level resistance to raltegravir and elvitegravir, and also with some intermediate reductions of dolutegravir and tegravir susceptibility. So these are some important cases, and in the case that this will arise, we need to think about double dosing, for example, for dolutegravir. Again, combination of the pathway that we'll know that will go, as I already mentioned, E138K plus 14H. So we need to think about these mutations that will arise together, and you'll need to think of the impact that will have on susceptibility for older integrase inhibitors, and but also for the new ones. On the other hand, this is just a few data that were presented last year at our National Congress in Romania, when we again look at newly diagnosed patients to see what will be the mutation. I will not talk about the whole slide. I want to emphasize that there are patients in which we do not identify any transmitted mutation, either for NNRTIs and NRTIs. And when we looked and when we switched for protease inhibitors, we can say that there are some mutations that are transmitted. Again, we need to think about the history of each country, the history of the patient in the country, and how will that impact the long term. So the conclusion of our batch resistance mutation and looking at this number was that we should consider this mutation that are both highly sensitive and specific indicators of transmitted drug resistance. Look and ensure that we talk to our virologists in the lab and see the impact of that mutation on resistance, on the patterns. And then we need to talk about population-based surveillance of transmitted resistance that we need to uncover and develop. Of course, we know that COVID changed our whole view of what's going on. So SARS-CoV-2 infections literally took over our labs, and now we are focusing more on that infections. But our HIV-infected patients, getting back to them and the resistance pattern, we'll need to look at them more deeply in the near future. So The special population I want to emphasize is this Romanian population that we called young by age because they were infected in the early childhood, as you can see over here, and now they reach a median age of around 27. So they are young by age, old by treatment, because they have been exposed to a lot of antiretroviral treatment, and they have aged with HIV. This is why it's really important to focus on this special population that now have migrated to all the countries in the Europe. So we do have a rise of hope because when you look at this 2020 view of the HIV, the pipelines, we will have some options for these challenging patients, but we need to look at that resistance daily in order to identify what can be an options for them. Of course, the new patterns, the new drugs, we really play an important role in the near future. So to sum up, we do have to think about resistance. We do have to think about the transmitted resistance. And I hope that I raised your attention regarding what will be the most important thing that we need to rule out when we talk about a patient. We need to gather up all the information that we have for our patients because all the exposures to their antiretroviral will have an impact of the strains of the virus that we have nowadays. So we need to pull up the available treatment that we have for them and look for new options, as I already tell you. And when we gather the two of them, the transmitted resistance and the acquired resistance, we do have to think of the patient because we talk about the virus, but we talk about a patient with a viral infection. So we need to have options for them and we need to look at further options for this kind of patients. And ending up, I really like these slides because it applies to what's going on. Now our resources in getting all the lab tests as quick and as quick as possible for our HIV infected patient has a little bit of a delay. But even if we do have all the resources, it's really important how we can use them. So even in the COVID area, so to say, we need to look at our patients and try to pull out the available data that we have, look at the history of the resistance regarding acquired resistance for our patients, and test the resistance for the new patients in order to link that special population to the care. Thank you.
Much, Dr. Anca Streinu-Cercel. Dr. Anca Streinu-Cercel is a senior specialist infectious diseases at the National Institute of Infectious Diseases, Professor Dr. Matei Balz in Bucharest, and an associate professor in the infectious disease department, Carol Davila Medicine and Pharmacy University in Bucharest, also in Romania. So this was an excellent talk, both by Dr. Teymur Moori and by Dr. Anca Streinu-Cercel. So we're going to move now to the abstract-driven presentations, and we have 3 presentations. The first one is by Dr. Miloš Parševski. He is at the Pomeranian Medical University in Szczecin, Poland. He will talk about infection with subtype D adversely affects the life expectancy among people living with HIV from northwestern Poland. Then we will have Federico Garcia. He will talk about HIV trace versus phylogenetic analysis, unraveling transmission clusters in Spain. And Federico Garcia is from the Hospital Universitaria San Cecilia, Granada, Spain. And then the last speaker will be Virginie Mortier, and she is from the University of Ghent, and she will talk on behalf of the Belgian AIDS reference labs about prevalence and evolution of transmitted HIV drug resistance in Belgium between 2013 and 2019. So I will give now the word to my friend Milos.
We would like to thank, firstly, for this kind invitation to present our data on infection with subtype D and data on mortality related to this subtype compared to subtype D from our cohorts from northwestern Poland. So we perfectly know that subtype D has been localized epidemics in our region in northwestern Poland, where you can see on the map where we are located on the border with Germany. And we have already done some phylogenetic analysis where this infection is originating. We know that the sequences were seeded from Uganda some time ago, and in the models we also know that majority of these infections are spreading by heterosexual exposure, with patients being of Caucasian origin and not traveling abroad. So these are Polish, locally infected, mostly female populations with late diagnosis, which we have seen previously. We also know that this cluster has been seeded around 1990 with a huge number of transmitted drug resistance subcluster within the whole data set. So we know about it already. And here, for this analysis, we aimed to look at the survival disparities between the most common, approximately 85–90% subtype B infected population versus this much more rarer subtype D. So the data are as follows. The data set is of 455 Caucasian non-immigrant patients, all Polish origin, followed up from 1996 to 1990. So we have quite long follow-up by now. 86% is subtype B infected, 13% subtype D. Calculation of a survival was from time zero, which was either date of positive screening for HIV confirmed by Western blot or immunoblot or positive serum HIV RNA, and end of observation generally death date, last recorded date of visit, or January 31, 2019, which was the termination of data collection. The two subsets were created for this analysis, entire subset, and also we have included only people on card as a subset for this analysis. If we could not extract the date of death, so we have taken the median date between the last recorded and information on the death from the national database on the death of patients, which we have. Also, we have censored this analysis at 20 years of observation. So, as I've said, two data sets were created: overall survival from the date of diagnosis until death, and on-treatment survival from the date of card initiation until death or end of observation. Two standard statistic models were used: firstly, unadjusted and log rank, and then multivariate proportional hazards models to see the effect on the of variables on the survival, with standard p-values being implemented in the statistical analysis. So as you can see, mean observation time for the analyzed cohorts was slightly above 100 months, with overall all-cause mortality in the entire cohort being 13.166%. On mortality for the antiretroviral treated individuals was 12.7%. And you can perfectly see that actually subtype D is significantly older than subtype B infected patients, with higher percentage of females, with almost exclusively infection by heterosexual transmission route compared to the most common MSM transmissions for the subtype B, with higher number of AIDS in the history at baseline, higher baseline viral load, and lower baseline CD4 count. All these values were significant. Also, when we just calculated the mortality among subtype D people for the entire cohort and for the antiretroviral treated patients was significantly higher, being 30% and 25% for the subtype D, and 10% and 10% for the subtype B. So even here, the mortality differences were significantly observed. For the analysis of survival for 20 years, you can see in this Kaplan-Meier curves that both overall survival and on-card survival is actually significantly different for subtype D. Subtype D is notably associated with higher risk of death, and this was not mitigated by the antiretroviral treatment. Also, when we have taken most of the data which we had for these patients for the 20-year all-cause overall mortality and 20-year all-cause on-card mortality, we could see that only two variables were independently associated with higher risk of death: age, obviously, and subtype D, both for overall cohort and on-card cohort. So to conclude, we noted that subtype D has independent deleterious effect on the survival in the setting of antiretroviral treatment, and this is the long-term data. And this observed effect indicated higher clinical need for vigilance among patients infected with this subtype. Thank you very much for this opportunity. I hope the data is interesting.
Hello, everybody. On behalf of CORIS and our co-investigators from Italy and Greece, I am happy to present our data on HIV trace versus phylogenetic analysis, unraveling transmission clusters in Spain. As you may know, HIV-1 trace is a new computational tool to identify molecular transmission clusters in large databases. This approach is based on viral genetic relatedness to a reference sequence in order to construct and to visualize the connections among clusters. In this study, we have aimed first to identify transmission clusters in CORIS cohort by using HIV-1 trace, focusing on B subtype patients. Second, we aimed to compare those results from other phylogenetical approaches. For this study, we used the RT sequences available from newly HIV diagnosis in 2018 in CORIS. HIV-1 trace was used to estimate transmission clusters in 484 subtype B antiretroviral naive patients. We also used phylogenetic analysis using maximum likelihood method with bootstrap evaluation using the GTR+G as nucleotide substitution model. Sequences were phylogenetically analyzed along with all the most similar sequences as identified by a blast search. And LTNs, local transmission networks, were defined as phylogenetic clusters including sequences from Spain at proportions above 70%. So these are the characteristics of our HIV-1 trace network. Out of all the patients we studied, 130 patients were in clusters. We have found a total number of 54 clusters with a mean cluster size of 2.4 and a median cluster size of 2 patients. The lowest number of patients in the clusters was 2 and the highest was 6, with an interquartile range of 2 to 3. Here you can see the HIV-1 trace network representation in a spatial representation coming out from the DataMonkey web server. The node size represents the number of patients. We have seen before that the number of patients included ranged from 2 to 6 patients. So these bigger dots are those representing the clusters formed by 6 patients, and the smaller dots are those represented by or formed by just 2 patients. Here you can see the trace network epidemiological characteristics. Most of the patients were men. There was no differences in the geographical origin of the patients. Almost half of them were Spanish and almost the rest of them were from abroad. A great number of clusters were formed by patients that were geographically related, and the most frequent route of transmission was men having sex with men. Interestingly, when we looked at those patients that did not have a geographical relationship, this is, they didn't live in the same cities in Spain, we found that most of them were MSM. We found a very high prevalence of MSMs in these patients that clustered with no geographical relationship. And we also found a very, very close relation with 3 big cities in Spain, which are Barcelona, Sevilla, and Madrid. And here in this graph, you can see what are the migration or movements of these patients and where did they come from and where did they get infected. Finally, when we looked at the same cohort but using phylogenetic analysis, we found that more patients clustered together. By phylogenetic analysis, 154 out of 484 patients were in clusters versus 130 patients by the HIV-1 trace engine. And the number of clusters was also higher using phylogenetic analysis, 63 using Phi and 54 using the HIV-1 trace tool. Interestingly, when we looked at the comparison between the number of clusters and the number of patients in each cluster, comparing trace versus Phi, we found a higher proportion of clusters with 2 patients when we used the Phi analysis compared to the trace. And we also found that no cluster with 6 patients was found with the phylogenetic analysis, while we did find some with the trace analysis. So with this, we would like to conclude that the implementation of HIV-1 trace as a new tool is feasible and allows to identify transmission clusters. We also found that HIV-1 trace is an easy-to-use tool allowing the identification of transmission clusters. Our data revealed that HIV-1 trace identified fewer clusters among the B subtype Spanish patients than traditional phylogenetic approaches. Differences were mainly driven by the non-use of a threshold in the patristic distances in the Phi analysis. And finally, we would like to conclude that we believe that more phylogenetic studies are necessary to assess the sturdiness of the new HIV-1 trace tool. So with this, I would like to finish. I would like to acknowledge all the people from CORIS. I would also especially like to acknowledge the teams from Greece, led by Dimitris Paraskevis and Evangelia Kostaki, and also from Italy, led by Mariella Santoro and Luca Carietti. So thank you very much, and I will be happy to take any questions. Thank you.
Good afternoon. Today I would like to present the results from a joint collaboration between the Belgian AIDS reference labs, which is dealing about the prevalence and evolution of transmitted HIV drug resistance in Belgium between 2013 and 2019. To analyze the prevalence and evolution of transmitted drug resistance in Belgium, a multi-laboratory retrospective study was conducted by the 8 Belgian AIDS reference labs. ART-naive, recently diagnosed individuals were included in the study. A partial HIV-1 poll region covering the protease and reverse transcriptase regions were amplified and sequenced from baseline plasma samples using an in-house assay. Because monitoring of transmitted integrase resistance was only introduced in 2018, the study focused on protease and reverse transcriptase mutations. To be included in this study, the patients had to be newly diagnosed between 2013 and 2019. In total, 3,713 protease and reverse transcriptase sequences from as many individuals were analyzed. As observed on the graph on the right, the distribution of samples throughout the years was normal. Drug resistance mutations were scored using the Stanford HIV drug resistance algorithm, and also for subtyping, the Stanford algorithm was applied. For the population enrolled in this study, 47.5% was infected with an HIV virus of subtype B. Statistical analyses were performed using SPSS statistics. We mainly assessed trends over time using linear regression. Phylogenetic analysis, on the other hand, was performed to improve insight on the origin of the transmitted drug resistances. HIV trace is an application that identifies potential transmission clusters within a supplied FASTA file. For our analysis, all standard options were retained. Now let's have an overview of the results. This graph depicts the prevalence of transmitted drug resistances when the Stanford algorithm is used. In this case, all patients were included which were infected with a HIV strain harboring at least one mutation. If more than one mutation was present within a patient, the different Stanford scores corresponding with the different mutations were additioned. For this analysis, only patients with a Stanford score of 15 or more were taken into account. A mutation is given a Stanford score of 15 or more if it results in low-level, intermediate, or high-level resistance to one or more antiretroviral drugs. According to the selected algorithm, an average of 17.9% of the analyzed samples harbored at least one transmitted drug resistance mutation. No significant change in prevalence was observed over time, as a p-value obtained for linear regression analysis equaled 0.225. In this study, the majority of the observed mutations impacted NNRTIs in 11% of the cases, followed by NRTIs in 6% of the cases and PS in 2% of the cases. Multi-class resistance was observed in 2.4% of the studied population. The following graph illustrates the impact of the cutoff chosen for the Stanford score. The evolutions are quite similar, but the overall percentage of transmitted drug resistance mutations is inversely proportional. Taking into account all mutations resulting in low-level, intermediate, or high-level resistance, The overall average is 17.9%. For intermediate and high-level resistance, the average is 9.7%. And looking only to mutations resulting in high-level resistance, the average drops further to 6.3%. Let's have a closer look to the prevalence of individual mutations. When only those mutations with a high presumed impact on resistance against at least one drug were considered, the most frequently observed NNRTI-associated mutations were the K103N, Y181C, Y188L, and J190A mutations. The M184V mutation that confers resistance to NRTIs was detected in 32 patients. Transmitted drug resistance to protease inhibitors was found to be low, with only 12 patients harboring either the N88D or L90M mutations. A slight increase over the years in the prevalence of K103N and a decrease in prevalence of M41L was seen, but this evolution should be observed over a longer time period for the K103N mutation, as statistical analysis was not yet relevant. The high prevalence of the K103N mutation made us wonder whether this could be the result of clustered transmission. Based on phylogenetic analysis, we decided for each patient whether he was part of a cluster or no, and a cluster was defined as a group of at least 3 patients. In case of the K103N mutation, 26% of the patients harboring this mutation were part of a cluster. For the PI mutation N88D, the percentage of cluster transmission was 75%. In this slide, we have a closer look to those clustered transmissions. Depicted in the graph are those transmitted drug resistance mutations for which at least 50% of the patients harboring these mutations are part of a cluster of at least 3 patients. 81% of the frequently observed T215E mutation could be explained by clustered transmission. If we have a closer look to the other T215 mutations and revertants, we see that the T215E is clearly standing out. In conclusion, in Belgium, the overall prevalence of TDR remained stable between 2013 and 2019 and is comparable to the prevalence observed in other Western European countries. The high frequency of NNRTI mutations requires special attention and follow-up. TDR prevalence is to some extent driven by clustered transmission. Finally, for future monitoring, we would like to include integrase sequencing. This study was a joint collaboration between the 8 Belgian AIDS reference laboratories. I would like to thank them for the nice collaboration, as well as my colleagues from the AIDS reference lab of the University of Ghent, who also contributed to this work.
Thank you, everyone, the 3 speakers, for their excellent presentation. So now we are going to have the Q&A session. Please open on the right of your screen the live Q&A box and type in your questions. So we have all the speakers here, and we are going to have questions for all the speakers at the same time. Well, not at the same time, one by one. So let's start with questions for Dr. Teymur Moori. A question from Kirsten White. So how is a PrEP evaluated in the strategy for controlling the HIV infection? There is no specific target for PrEP, or how do I see that?
Yeah, so UNAIDS have developed global targets for PrEP, and the global target suggests that 3 million people should be on PrEP by 2020. It doesn't say anything about regional targets, and it doesn't say anything about which groups need to be on PrEP. So we're trying to monitor this in Europe, and we've asked UNAIDS to help us develop regional specific targets. So far, we don't have any. But what we're trying to do is monitor, first of all, a policy question if PrEP is implemented in countries in Europe and Central Asia. And the latest data we have suggests that around 18, 19, maybe 20 countries have implemented PrEP in the sense that it is funded by the healthcare system. Another maybe 5 to 8 countries, they have made generic PrEP available to a relatively low price, around 50 euros per month. And especially in the eastern parts of the region, PrEP is not available at all. That doesn't mean people are not on PrEP. We know that people actually can acquire PrEP through internet or through other means. And that, of course, is concerning because that means they're not probably monitored appropriately. But so in terms of the numbers of people on PrEP, only maybe 15, and those numbers are still relatively small. They're quite large in France, in the UK, primarily those 2 countries, and Germany is increasing quite dramatically as well. Those are the 3 countries where we've seen most implementation.
Yeah, yeah. Well, how would you judge the importance of PrEP in controlling the epidemic?
Well, PrEP is going to be critical if we're going to meet these targets. In several European countries now, we're starting to see a reduction in HIV incidence. And we're trying to attribute this to combination prevention. We're trying to measure what kind of interventions these countries are seeing, especially among gay men. And PrEP, one common factor in all these countries is that PrEP implementation has been implemented in these countries. So I think in order to meet the 1990 targets, we need to stop people from getting infected in the first place. And that's where PrEP comes in, especially among gay men, but it's not being reached to other key populations.
Okay, so shouldn't we have some easier to measure target for PrEP then?
Well, I mean, it's not a matter of easy or not. We just don't have a regional target. So I think what we need is, what is the target for Europe? We don't know what that is. So we need to ask UNAIDS what that modeling is. I think 3 million people by 2020 globally is too. So I think they're in the process of revising their targets now that 2020 has almost passed. They're developing new political declaration in 2021, where maybe hopefully they'll go into more specifics and provide more specific targets.
Okay, thank you. Another question for you, Dr. Moori, from Stefan Dressler. So he thanks you for the presentation, and he wants you to comment on stigma and discrimination, and whether there are specific tools to measure that, and is CDC providing such tools, and if not, are you planning to develop such a tool?
Yeah, so this is a really important question. I think of the 3 SDG targets, the overall targets, this is the one that's going to be most difficult to reach. No stigma and discrimination in our region. That's really, really difficult. We have something called the Stigma Index that a few countries are implementing, but it's not widely spread. It's very difficult and costly to measure this. So we actually just had a discussion with some people in our network yesterday on how to address this issue. So we think that working with EACS, the European AIDS Clinical Society, they've expressed an interest to try and measure stigma in the healthcare workers, HIV doctors, etc. So we're going to develop a tool, hopefully with them in the next year or two, to measure stigma among healthcare workers. But what we're still going to find very difficult to do is actually measure a perceived stigma in the community. And we're in discussions with our community partners to see if we can develop a simple tool that can be measured at least 2 or 3 times over the next couple of years to see if we're moving in the right direction with stigma reduction. Okay,
thank you very much. Thank you very much. The next question is for Dr. Anca Streinu-Cercel from Aurelia Horta Resendis. The question is about the integrase mutations after virological failure. What are the most common regimen that have been eliciting these failures?
Thank you for that question. It's really an important one, and I think it's the one that we are really interested in. So the data that I have shown you are regarding so-called first generation of integrase inhibitors inhibitors, I'm talking about raltegravir and elbitregravir, for whom we know that we do not have such a high genetic barrier. So the recommendation and what we did in clinical practice was to switch to either dolutegravir or even double dose dolutegravir because we have the means to do it. It's not co-formulated, and also bictegravir that we will have available soon in Romania as well, but it's available in other countries for a period of time. But that we cannot double dose because it's co-formulated.
Yeah. Okay, thank you. So another question for you. The birth cohort patients are really a very specific cohort of patients, and I think we can learn a lot from them. So are they having any other effects, side effects of treatment, or how are they doing in their daily life? Are there any specifics in this birth cohort?
Yes, that's a really good question. And we usually talk about so-called former pediatric cohorts that were children infected in the early childhood. So not mother-to-child transmission, but in the early childhood. And what we have noticed during their evaluation, we have some impairments like renal impairments, and we also identified osteoporosis in their cohort, so they are around the medium age of 27, and we are still monitoring them for other comorbidities that will appear. Of course, dyslipidemia and lipodystrophy is a major one that will impact their self-esteem, so to say, because we talked about stigma. This really impacts them more than osteoporosis or renal impairment, so to say.
Okay, thank you very much. Thank you. So now I have a question for Dr. Milos Parsiuski. So it's known that subtype B is a problematic subtype. I'm assuming that you subtyped your sequences in the RT region. Do you know if they are full-time subtype, full genome subtype D, or if particular regions are subtype D and other regions might be another subtype?
What we did for our cohort is the protease and reverse transcriptase and integrase sequences. All were pure subtype D. We have checked that with Comet tool and with Riga tools and confirmed that with phylogeny in other occasions. We do not have the possibility to do the full sequences, but we are now setting up a platform for the NGS, and these will be one of the first samples to be analyzed to confirm the pureness of subtype D in this context.
Yeah, because it's interesting to know it might be some particular genomic region of D that is particularly bad. Yeah,
that's an excellent issue, and we are now actually in the process of NGS optimizing. So we will grab the samples, and we have quite a nice data set for that.
Thank you. I'm looking forward to those results. And then I have a question for Federico Garcia. So am I concluding it correct that TRACE is a good tool if you want to draw statistical conclusions about the clusters, but not really if you want to deeply investigate an individual cluster?
Yeah, you're right. Thank you for the question. Yeah, those are the data. I mean, we have compared with classical phylogenetic analysis, and this works better than HIV-1 traits. But but I think that we started this this investigation because we wanted to use a tool that we could use all across Spain and a real-time tool. And you know that not all the labs can use a proper phylogenetic analysis. So our main objective was this. It was that we wanted to know if we could use this for doing real-time phylogenetic analysis. And for this, I think it's not ideal. It's not better than phylogenetic analysis, but it is a good tool for doing this job. You can trace the transmission on real time in your lab, and across all the labs that are doing resistance testing in your country.
Yeah.
For instance, in Spain, this is for 30 different labs. So I think it's really important to have a tool that you can use very, very quickly, and everyone can use it. And I think the trace tool is the tool for this.
Yeah, I would agree with that. Thank you, Federico.
Thank you.
Then I have a question for Dr. Virginie Mortier. Well, my first question would be, what is the rationale to use the clinical Stanford algorithm as compared to the surveillance algorithm to measure transmitted drug resistance?
Yeah, it's one. I'm sorry, I'm a bit confused by the question, but it has been updated quite regularly, what is not always the case with other lists of surveillance drug mutations. And then we personally made comparison between the three different lists that are available, the way WHO, Stanford, and IS mutation lists. And then for this analysis, to not make it too complicated, we have been choosing the Stanford analysis because that is one that has been described in many articles as well.
Yeah, yeah. So how are the polymorphisms affecting your results? Because you're also measuring polymorphisms with that tool.
I should have a deep look into that. I'm sorry, I cannot answer this immediately.
Yeah. Okay. Okay. So then, Kristen White also wanted to ask you a question about transmitted drug resistance between primary versus chronic infection. How do you compare these data, and do you have the data?
Well, we don't have them readily available because, of course, it's not standard of care to monitor chronic patients who have been on therapy already. But of course, we sequence those patients who have failing virologically, and we could do an analysis on that. It would indeed be interesting to put those data next to the data we have now about baseline sequences.
Okay, thank you. Thank you very much. We have to round up the session. Thank you to all the speakers and also for answering the questions. And there is a Meet the Speaker event after the break. So then you should go back to your timeline and click the button join next to the name of the speaker when you want to go to that Meet the Speaker event. Thank you, everyone. And we will have the break now. Bye.
Thank you.